got the MRCPCH degree from Ireland 2008, and he had the fellowship of neonatal and perinatal medicine 2018, and the fellowship of the POCUS of neonatology, point of care of ultrasound 2021. And the topic that he will present is the assessment of crashing infant by the ultrasound. And we'll have 25 minutes, Dr. Assem. Thank you.
Good evening, everyone. I'm Dr. Assem Lashin from University of Manitoba, Canada. I'm going today to discuss the Crash Infant Protocol, or CIP. I have no conflict of interest to disclose. Before I start, I would like to thank Dr. Yasser Sayed. He is the original author of the article of Critical Infant Protocol, and for his outstanding dedication and care and helping for preparation of this presentation. Also, I would like to thank Dr. Raghda Ali, head of the pediatric department in Ahmed Maher Hospital, for her valuable help and outstanding effort in preparation of this presentation. Our objective today is to understand the meaning of the CIP protocol and understand the definition of crashing infant. Also understand the basics of the 4 modules of the CIP, and finally demonstrate the value of using point-of-care ultrasound as a diagnostic tool which can be performed by all trained neonatal and pediatric practitioners. This is actually the original study published by Dr. Yasser Sayed and his team in the hemodynamical team on Canada. It is the point-of-care ultrasound protocol for systematic assessment of the crashing neonate, and it was published in the European Journal of Pediatrics. So from the first beginning review of this study, we can say that the CIP, or the Crashed Infant Protocol, is a multi-organ assessment by ultrasound in any infant with acute hypoxia or hypoxemia. The protocol involves a stepwise systematic assessment with basic ultrasound views, which can be easily learned and reproduced. All of us know that the ultrasound is more quick, cheap, portable, repeatable, accurate, non-invasive, and hazards-free because he contains no radiation. So that makes it as ideal tool for diagnosis and therapy. The infant protocol is so close to the pediatric protocol of SAFE, S-A-F-E, which contains also the ultrasound assessment for the heart, lung, aorta, abdomen, and brain. So there is some similarity between the crashed infant protocol to the SAFE protocol in the older children. At the beginning, how do we identify the crashing infant? What do we mean by the crashing infant? Let us say it is infant unresponsive to resuscitation or in shock with poor perfusion, acute hypoxemia, or even unexplained anemia. How we can perform quickly the critical or crashed infant protocol? It should not exceed 10 minutes for assessment, and it should not interfere with or delay the resuscitation process based on the NRB data and other resuscitation guidelines and protocols. The pathophysiologic mechanisms of the crashing infant, it will be within those mechanisms or actions, including lung collapse, infiltrate or consolidation, pleural effusion, pneumothorax, and we can say those are from lung origin. From the cardiovascular causes, volume depletion, myocardial dysfunction, pericardial effusion, pulmonary hypertension, arrhythmia, and of course, duct-dependent congenital heart disease. Other internal organs, gut ischemia, internal hemorrhage, brain hemorrhage, or neonatal stroke. And finally, some other systemic reasons, including the metabolic diseases, septic shock, endocrine causes, and toxicity and drug related. So those are, in summary, in brief, the most common 16 causes and pathophysiologic mechanisms of any crashing infant. So based on those causes of the crashed infant, they classified the protocol of the crashed infant into 4 categories, and the 5th one will be included in the cardiac POCUS. So the first module will be the lung, looking specifically for the pneumothorax, pleural effusion or atelectasis, followed by the cardiac POCUS, looking for shock, tamponade, and hemodynamic instability. Then the cranial part with acute brain hemorrhage, followed by the abdominal part, looking for peritoneal or subcapsular bleeding, gut injury, or bowel ischemia. And finally, the central line related complications, which most probably and very commonly to be included in the other modules, especially the cardiac assessment modules. So we mentioned that the most common causes of crashed infant is around 16 causes from different systems. And here also we have around 16 steps or sweeps to be done within 10 minutes in our crashed infant, trying by the use of the skills of ultrasound to figure out a reason and physiology-based understand of those deterioration and of course affecting the decision for management. So the first part or the first 3 parts are lung-related sweeps, including the right and left lung with anterior right sweep, lateral right sweep, and anterior left sweep, and finally the lateral left sweep. The anterior sweep usually in the mid-clavicular line start from up to down, and the lateral one usually in the middle to the anterior axillary lines from up to down too. So we'll perform 4 steps, 4 sweeps in the lungs, looking for a specific diagnosis, pneumothorax, pleural effusion, or consolidation atelectasis. Followed this by cardiac assessment. So we'll go here to the apical 4-chamber view, followed by long axis and short axis of parasternal views. Again, looking for cardiac tamponade, cardiac contractility, cardiac filling, and volume. Then we'll go to the abdomen, 1 view to the liver, followed by mini abdominal views, right upper quadrant of the abdomen, right lower quadrant of the abdomen, left and upper and lower quadrant, then going to the midgut, spleen, and finish the abdominal ultrasounds, again seeking for effusion, ascites, fluid collection, hemorrhage, and or ischemic bowel. And finally, we'll end by 2 sweeps on the brain or cranial ultrasound, one for the coronal sweep and the other for the sagittal sweep. So start by the lung, finished by the brain, passing through around 16 steps of sweeps and 16 locations of sweeps. First module is the lung ultrasound. As we mentioned, we are looking specifically for the collapse atelectasis, which required a decision for lung recruitment, either by modifying the map or giving surfactant. The second part, we are looking for pneumothorax. And the third was pleural effusion, and both of them are treated with needle thoracocentesis. And again, specifically, we are looking for those diagnoses and those acute reasons for the crashed infant. For notice, we are not going to do the ordinary lung scoring with the 6 markers of the lung on the right, R1, R2, R3, L1, L2, L3, and for the effusion, the R4 and L4. Here we are looking mainly for the effusion, but with a different technique. We are doing a longitudinal sweep. As we mentioned, 4 sweeps, the anterior right sweep from the midclavicular line downstairs, and then the lateral right sweep, and the anterior left sweep, and lateral left sweep. You will take the probe, and from the upper part of the chest down, looking for pleural effusion, pneumothorax, or lung consolidation atelectasis. This is the normal pictures and the abnormal pictures, very well known. We are not going to review this today. This is the normal lung pattern with A line and some hazy B lines, incomplete or Z line. Here is the signs of increased interstitial fluids, of increased B lines, which is vertical longitudinal lines, as we can see here. And in the third one, we have coalescent B lines, which indicates intra-alveolar edema. And finally, the last one, the pictures of air bronchogram and fluid bronchogram, which means the most advanced score of lung disease. So here we are not going to do the ordinary score of the lung, but we are just following and looking for those 3 diagnoses: pneumothorax, consolidation, and or pleural effusion. For the pneumothorax, for example, everybody knows what is the signs, the ultrasonographic signs of pneumothorax, which includes absence of pleural line sliding and no B or Z lines, lung point, which we mean by the lung point that you have a normal lung tissue as well as abnormal lung signs at the same frame. So it's called the double lung point of pneumothorax. And finally, the presence of what's called the barcode sign, which is detected by the M mode. Here we can see the M mode of the lung ultrasound, showing this part is the chest wall, including the subcutaneous muscles, the ribs, and others with limited movement. And this is a pleural line, which is a white horizontal line here. And here is the normal lung sliding, and each movable or sliding tissue will appear in the M mode as continuous dots or sandy beach sign. So the sandy beach sign is a normal lung sliding picture. You can find the lung tissue, as we can see here, in multiple dots. However, in the pneumothorax, again, this is a chest wall, the above the pleura, and the white horizontal one, the hyperechoic, is the pleural line. And here we can see absent lung sliding and giving us the pictures of the barcode. Keep in mind the previous slide, which shows the sandy dots of the movable tissue of the lung. Here, the tissue of the lung under the pleura is not moving, so appears as a horizontal parallel lines with different thickness and different echogenicity, and giving the pictures of the barcode. This is a typical barcode we mean, and this is a typical signs of the barcode with the most common and most famous sign of pneumothorax. This is the exact difference between the normal lung, which has the seizure sign, where you can see here, if you look deeply, you can see the sand picture and the different dots pictures. While in this area where we have the barcode sign, there is lines, horizontal lines here in parallel to the pleural line. So that means this tissue is not moving sufficiently because of the pneumothorax, and they give us the pictures of barcode, while this is a normal lung tissue, and both of them present at the same frame, so it's called the double lung point of pneumothorax. The second diagnosis we are looking for is the pleural effusion. To know that chest X-ray is having a lot of problems with the diagnosis of the pleural effusion. We can imagine that the X-ray need a minimum of 150 ml of fluids to be seen and diagnosed clearly by the chest X-ray. While in the ultrasound, you can detect effusions as small as 5 to 10 ml. The sensitivity is around 93%, and sensitivity is around 96%. Ultrasound also can distinguish between the transudate as well as the exudate. It's the exudate called the complex effusion, where you can find some many cellular elements in the effusion itself. These are pictures of hypoechoic area between the pleura, and this is the pleural effusion here. And you can find here the lung tissue, which is collapsed by the pressure of the effusion. And this is a part of the diaphragm, part of the liver. So most probably we can see the pleural effusion in the costophrenic angle left and right by the R4 and R3 of the lung ultrasounds. But in this summarized module of the lung ultrasounds, we can find it by the longitudinal sweeps, as we mentioned, especially on the lateral sweeps on the right and the left side, from up to down, and you can find it down in the costophrenic angle. Here are very famous two signs of the pleural effusion, ultrasonographic signs. It's called, the first one is called jellyfish sign, which indicate this part of the atelectatic lung tissue, in which it's moving in a fluid, looks like the jellyfish. And if we'll do M mode in this area, the pleural line will keep moving, and the lung line will keep moving toward the pleural line during inspiration and expiration, giving what's called the sinusoidal sign in M mode. You can find a wavy signs by this way. It's called the sinusoidal sign. So jellyfish sign and sinusoid sign, both of them can help in diagnosis of pleural effusion. We can also, by the ultrasound, as everybody knows, to assess the amount of the pleural effusion. So we can measure the pleural effusion in centimeters from chest wall to pulmonary parenchyma. As we can see here in this pictures, it's from the pulmonary wall to the lung tissue or pulmonary parenchyma, and then we can decide how many times we can tap and how much the amount expected to come out after tapping. So now, This is a summary for the lung, as we mentioned. For example, this lung has a lot of air bronchogram and atelectasis. So here we'll adjust the main airway pressure. This lung has pneumothorax with the double lung point, as we can see here. This is almost the normal lung, and this is a abnormal lung with only A line, no B line, no sliding. So this one will aspirate the air, and here there is pleural effusion surrounded by massive pneumonia also under consolidation. And of course, we'll do urgent tapping for this one. And mostly also we need antibiotics to treat the consolidations, which could be infective in order. Okay, so this is what we need to know about the lung. We are not going to discuss in detail the lung ultrasound and the scoring system. As we mentioned before, we are just looking for some specific diagnosis which can help us to figure out the causes of the crashed infant, and we can also help by following a therapeutic measures based on those diagnoses. Second module is a cardiac POCUS. Again, we are not looking for the congenital heart disease. We are not looking for the detailed TMA echo functional assessment of the heart, but we are again looking for some specific indications. Number one is the tamponade, which we can produce, do pericardial cardiocentesis, poor contractility, which we can start inotropes, and pulmonary hypertension, which we start treatment for the PPHN with pulmonary vasodilator, nitric oxides, and other medications and modules, and empty heart, where we can start by fluid and volume load. So the common cardiac problems, as we mentioned, the cardiovascular volume depletion, myocardial and ventricular dysfunction, effusion, pulmonary hypertension, arrhythmia, and of course the duct-dependent congenital heart disease. It's multiple views, including and limited. For those views, we are again not looking for the detailed functional assessment of the heart with detailed views. We are just going to look for the parasternal long and short axis, apical, four chamber. This is the main three views we are looking for. And some others, they can quickly look for the subcostal views, especially for assessment of central lines, if we have central lines under discussion. So this is a very common and very well-known parasternal long axis views, from the starting by the left atrium, followed by the mitral valve, then the left ventricle, and the most anterior is the right ventricles. And here we can see the left ventricular outflow tract with aortic valve and the ascending aorta in this part. So we can look for the parasternal long axis quickly to see the contractility, to see the filling of the heart, and to also to detect if there is any tamponade and pleural pericardial effusions. And of course, this is the descending of aorta, but it's a cut through, so we can see it as a circle like this. Short axis view, again, right ventricle, left ventricle, interventricular septum, and we can see from this view also the effusions, and we can see the contractility, and we can start have a more clear idea about the pulmonary hypertension, if there is any deviation of the system, paradoxical movement of the system, of the septum, and diagnosis of ventricular septal defects and this other tamponades. The very famous apical four chambers view, including the right atrium, left atrium, interatrial septum, and this is the tricuspid valve, right ventricle, left ventricle, interventricular septum, and the valves here also mitral valve and tricuspid valve as mentioned. From the four chamber views, we can see again the septum deviation and septum position. We can see if there is any cuspid prolapse or tricuspid regurg, which can give us idea about the pulmonary hypertensions, and we can start to measure the tricuspid regurg. Of course, we have the other measures here, but it's again out of scope of this assessment to look for the details of the left ventricular and right ventricular function. But again, we are just looking here for the contractility, for the filling of the heart, for the signs of the pulmonary hypertension if it is there quickly, as well as the pleural pericardium and mediastinal effusions. This is a subcostal view just to have a look for the inferior vena cava with the hepatic veins. Here you can see the inferior vena cava is dilated, and here you can see it's contracted with inspiration, and this is the end of the inferior vena cava. So this, we can get an idea about this part also from the subcostal view. So the pericardial effusion, collapse of the right ventricular free wall because of the pressure from outside, and the absence of the inspiratory collapse of the inferior vena cava. This is also could be detected from the subcostal. This is a baby was diagnosed with pericardial effusion after malposition of the central line, and it was TPN effusion and was tapped by this way, so drain fluid in the wrong place, pericardiocentesis, and the baby survived after that. So in brief, this is a four-chamber view for severe underfilling of the heart, and you can see here the chambers of the heart is almost empty of fluid, so this one will go for volume, and this one is parasternal short axis view with dilated right ventricle and paradoxical movement of the interventricular septum, signifying a significant pulmonary hypertension. So the decision here is to start treatment for the PBHN, initiating the nitric oxide and other pulmonary vasodilators, correction of acidosis, hydrations, and all these issues. And here in the third pictures, you can see the fluid collection around the heart, which is demonstrating the pericardial effusion. And of course, the treatment here is ultrasound guided paracentesis and drain of this fluid around the heart. So this is the cardiac module, and as we mentioned, the cardiac POCUS is not a screening tool for the congenital heart disease, or even it is not a detailed assessment of pulmonary hypertension or ventricular function. Totally, this is out of the scope of this cardiac assessment. The third module of the crash infant protocol is a quick assessment for the abdominal ultrasound. By the abdominal ultrasound, we are looking for free fluid, hemorrhage, effusions, ascites, or gut ischemia, necrotizing enterocolitis, and other diagnoses. This is the plans, sagittal and the coronal plan of the abdomen. And those are the areas we are doing in the abdominal assessment. The items to be assessed by the ultrasound is by the 2D. We can see and have a look for if there is any free air or not, intramural air, portal venous gas, thickening of the bowel, thin bowel, peristalsis, intestinal signatures, and complex fluid or peritoneal fluid, ascites. And by the color Doppler, we can see the normal color flow, abnormal color pattern, absence color flow. And all this are the normal color, and this all three of them are abnormal colors. Usually we accepted from 3 to 9 different colors in one image. And if it is more than this, that indicates some kind of hyperemia, and if it is less, indicates some kind of gut ischemia. And there is some shapes here called zebra shape, and this is Y-shaped, and all of them are in abnormal pattern of intestinal ultrasound color. Here we can see the normal pattern of the intestinal ultrasound with normal color Doppler indicating normal blood flow for the gut, normal movement, normal peristalsis, normal thickness of the wall. There is no any kind of pleural, ascites or any fluid collections anywhere. So this is considered the normal bowel ultrasound. This is in contrary to the previous slide. This is the pneumatosis intestinalis. You can see here the white dots intramural inside the intestinal wall. That's the typical of pneumatosis intestinalis. This is some kind of absent peristalsis. This picture is severe neck with some kind of infusion. You can see here how the movement is sluggish, and in this area specifically there is some intramural gas, and this is a fluid collection ascites. So we need to initiate the necrotizing enterocolitis protocol as well as tapping those amount of fluid. So in summary, again, for the abdominal point of care ultrasound, we can see the effusions, we can see signs of pneumatosis intestinalis and necrotizing enterocolitis. Also, we can see here more clear pneumatosis intestinalis and management to the neck protocol. Now we'll go to the fourth module, which is the cranial point of care ultrasound. The module is mainly for the detections of intraventricular or intracerebral hemorrhage, like this case, which shows the severe IVH left parenchymal hemorrhage. This is the left parenchymal hemorrhage, and bilateral IVH. Those are the bilateral IVH in this picture. So the management here will be for neurosurgery follow-up, ultrasound follow-up, blood transfusion if indicated, and daily neurological assessment. This again, some grading of IVH, started by the germinal matrix IVH in those areas and increased on the lateral horn of the lateral ventricle, anterior horn of the lateral ventricle, and here there is some dilatation of the lateral ventricle. And this is a coronal section, and this is the sagittal section we can see here. This is a proposition for the start the cranial ultrasound, make it for the cranial, for the coronal, then you will change for sagittal. So this is a sagittal view or sagittal plans. You will get it from the left to right, and the coronal view from anterior to posterior. So now this is the simple discussions of the critical or crashed infant protocol. And here we have the training design for the point of care ultrasound. Training course with exam online, followed by a workshop. Then it's 1 day for each module. It should be by this way. It should be having some practice under supervision. Then followed by 20 to 25 studies, mixed variety of normal and pathologists. Then with on-site or remote supervision, 10 normal and mostly 10 abnormal. And if you need some special instructor certificates, you need to have around 50 studies of the advanced level of the modules. So this is a validated group of training design for the point of care ultrasound. And finally, the conclusion and home message today, the crashed infant protocol provides an organized stepwise guidance of assessment of unstable infant. Integrated clinical and POCUS is helpful to formulate physiologic based medical recommendations. the pathologic specific intervention is proven to be time saving and to help the clinical recovery. Thank you so much.
Thank you, Dr. Assem. Very illustrative presentation, actually. Does anyone have any question to be raised to Dr. Assem?
I'm so sorry for beginning. It became longer than expected.
Yeah, that's very interesting, actually, and it was very illustrative, actually. We have a lot of questions for you.
I'm traveling from country to country, so I recorded for one time, but I didn't have time to do it again. So I'm so sorry.
Thank you very much, actually. Is there any question for Dr. Assem? Okay, may I ask you, Dr. Assem, the probe you are using, the power of the probe, is it the same for all the areas? I mean, the one that you are using for the cranial ultrasound, is it the same probe with the same power that is used for the chest or lung and abdomen and heart, or it differs?
We used to use the curved one for the head.
Yes.
For the pleural effusion in the costophrenic angles, which is the curved probe, as well as assessment of the liver in the abdominal ultrasound. But for the lung, we are using the longitudinal one, and the same for the intestinal ultrasound, we are using the longitudinal tube. So you can say the heart, the brain, the costophrenic angles with pleural effusion, and the liver with the curved probe, and the lung and the intestinal ultrasound with the longitudinal probe. But in case of emergency, yes, like our situation with the crashed infant, I think, and Dr. Yasser can correct me if I'm wrong in this, we can use a one probe only.
One probe, because
probably will be the curved one.
Yeah, because in 10 minutes you have to do a lot of things, so you have to focus on this.
Yeah,
okay.
Exactly.
And then you will, I think someone who wants to ask a question, or?
Yes.
Okay, Dr. Safa, yes, تفضلي Dr. Dr. Safa Miniza, yes.
Yeah. What about the suprarenal? Are you also checking the suprarenal gland, whether blood flow or hemorrhage or whatever for the care of this crashed infant?
As a part of the crashed infant, no. We are not looking for the adrenal glands, actually.
Okay, thank you.
Okay. Another question, please. You talked about the sensitivity about for the lung. Is it the same for all the other areas, or the sensitivity differs from one area to another, for example, and there are factors that may affect, for example, thickness of the skin or movement of the baby, or the amount, or the sensitivity is the same?
I think it's a cumulative percentage for the sensitivity and specificity in all of them. For all of them, yeah. Because, finally, we are dealing with a neonatal age group, which yes, I don't expect a great difference from the thickness of the skin point of view. It's not, you are not facing chubby babies, or maximum you can have some kind of macrosomic baby or something, which I don't think it affects the results of the intestinal ultrasound or any other ultrasounds or lung ultrasound in the area. The variation is very limited here.
And when you receive the baby for the assessment, you have to go through the process in that sequence, or you may start with something. For example, if the baby is convulsing or the anterior fontanelle is bulging, you will start with the cranial ultrasound, and then you will go through the other areas, or you have to go through the areas in the 4 areas or the 5 areas in the same way.
It's not a wrong and right order. It's just order to keep it easier for the people to understand and to remember it. Just go for lung, then move from the lung to the heart, and then move from the heart to the belly, then from the belly to the brain. But if you started this or that, I don't think there is any difference at all. Do it by your own way, which is more comfy for you, for whatever. But I think the more instant causes, which is corrective causes, logically it will start from that. If I found IVH, for example, what I can do immediately for this, very conservative management. But if I found pleural effusion, which I will look for first, this is something I can do it within minutes. This
Yes.
baby I give the picture for, he was saved within minutes, and he stayed by this needle one minute. And I think Dr. Yasser, remember him, and he was our colleagues, and we saw it in our unit. So pericardial effusion, pneumothorax, pleural effusion, all these very acute, correctable situations, I can say it had the priority to go through it. And finally, we are trying to limit ourselves by the period of 10 minutes, which make the difference between if you start by this or that negligible. But again, I prefer personally, and I think the protocol, which was written by Yasser and the group, prefer this to start by the lung. You can find the most corrective causes there, then followed by the heart, then followed by the intestine, and finished by the brain.
The study, this fellowship study, how long does it take? Is it months or 1 year or 2 years or what?
What the point of care?
Yes, the POCUS
the
itself.
Point of care is one year. 1 year,
1 year
fellowship. Yeah.
Okay, and the training, they should be all available in one center, or you move from one center to another according to the availability and the experience of the area, for example.
We have the
Dr. Yasser, I know because we have discussed it before. I know, but I want to know more about it.
Yasser. But what I did, he was my supervisor, and I took the 1 year with him, and we took it in one center in
one center because
Manitoba,
all the
but the details of the program itself, I think Yasser is the most suitable person to answer about it. Yeah.
Okay,
thank you very much. So far, it is only available in one center in Canada, which is our center in Winnipeg, and the other center in US, also one center in Philadelphia. So in North America, there is so far only 2 centers. And the other centers, they can consider point-of-care ultrasound practice, but with not accredited fellowship. So these are the only 2 centers in North America with the fellowship training.
Okay, thank you. Thank you very much. Okay.
Thank you.
Next will be.
Thank you.
Thank you, Dr. Sameh. Who's next?
It's my turn.
Dr. Iman, sorry, Professor Iman, تفضلي.
Good evening, good morning, good afternoon. My name is Iman Badran. I'm Professor of Pediatrics and Director of Neonatal Unit and Neonatal Fellowship Program at University of Jordan. I have the pleasure today, thank you for Dr. Sameh for inviting me to moderate this very important session. Now let's start it and go with the fourth speaker, Dr. Yasser Al-Sayed. Dr. Yasser will be discussing the cardiovascular medication stewardship in the ICU. Dr. Yasser is Associate Professor of Pediatrics at the University of Manitoba. We are so happy for his professional achievement. He's the founder and the director of Integrated Hemodynamic Program and Point of Care Ultrasound. And as he said, he designed the AI clinical calculator, which is so helpful for clinical decision support in the neonatal ICU. He had over 100 articles, book chapters, and he conducted a lot of workshops, around 100 workshops at local, regional, national, international places. His innovation in neonatology is very well known. He's founded the first internationally recognized website, the POCUS.org. Thank you, Dr. Yasser. We use it a lot in our unit. And the NeoPed Academy for Virtual Education in Medicine. And he designed the Manitoba Neonatal Educational Learning Management System there. And his key contributor and his key contributions where he founded the lung ultrasound program, which replacing the X-ray for diagnosis of lung disease, as have been said in the last